EMSradio.com.
EMS information for the next generation.
The EMS Garage is a production of EMSradio.com. You can find us on Facebook, just search EMS Garage. You can find us on Twitter at EMS Garage. Email us, emsgarage@gmail.com, or call us, 303-720-6001.
The EMS Garage.
Almost ran into the store with his vehicle. Checking out right now.
Okay, I got DG on the phone there. Want to know if you can handle that call as well. Just confirming you are checking the patient.
Sale 922 is on scene. Here's buddy.
Hello everybody and welcome to the EMS Garage / EMS World podcast, coming to you from EMS World Expo in Nashville 2018. And today I'm joined with Dr. Salim Rezaie.
It's Rezaie. It's
Rezaie.
okay. There's a lot of vowels. There's a lot of vowels
so
in there.
Sorry,
it's
Doc.
okay.
I'm going to call you Doc. How about that?
That'd be fine. That'd be fine.
So Doc, tell me a little bit about where you're from and what practice you're doing.
Right. So I'm from San Antonio, Texas. I'm a community ER doctor. I work out of 5 or 6 different types of ERs. Some of them are standalone facilities. Some of them I have some specialists, and other ones I not so much.
You're the only guy.
I'm
right?
Yep. I'm the only one making those decisions and running those things. So it's like kind of working pre-hospital with a limited man/woman crew.
That's very cool. And you're here at EMS World talking about stepping outside of ACLS a little bit?
Yeah, a little bit. So I think the guidelines are fantastic. They were created for people who don't get to run resuscitations very often.
Good point.
But for those of us that are doing this on the front lines, that are actually taking care of these patients, there are really only 2 things that have ever been shown to improve survival with good neurologic outcome. And that is early, high-quality CPR with limited pauses and early defibrillation. So are there things that we can do that maybe the guidelines don't tell us to do or maybe don't suggest that could let us still run the code well, ensure that they're getting those things that matter, but also let us focus on the patient in front of us? And I think there are a few things that we can do, both in the pre-hospital world as well as in the emergency room.
So are you a medical director for any pre-hospital organizations yet? Okay.
I'm not.
So let me ask you this, because I can now get your unbiased opinion. When you see paramedics bring in patients that are in resuscitation or have been resuscitated, what's a big pet peeve?
Oh man, one of the biggest pet peeves is the one arm over on the stretcher CPR. I can't stand
We call
that.
those glory compressions.
Yeah,
in my
I get why they're having to do
Right,
that, but
right.
I just can't. That's not good perfusion.
Well, we have devices to take care of that.
That's
now.
exactly right.
Right. I mean, that's the point of them. So when you see that, do you ever talk to people about it, or do you just say, stop in your ambulance, you're still doing good compressions, let me come to you? Do you ever do that for them?
Yeah, sometimes we do. It depends on what the report is and what the duration of time is that they have to get to us. And so sometimes we can prepare ahead of time. So one of the things to cognitively offload is I do believe in the mechanical CPR devices. I know the evidence hasn't really borne out in terms of showing survival with neurologic outcome benefit, but my contention is twofold. Number one is, just like any other technology in the world, if you don't practice with it, you're not going to be efficient with it.
Right.
And that is still delays in high quality compressions in CPR. So I think, one, we need to practice with these devices. And the second is that we need to have a plan of how we're going to do this. So let me just explain what I do in the ER that I think minimizes these pauses. We have Lucas devices. So there's 2 types of mechanical CPR. And we'll put the back of the CPR device with the defibrillator pad actually on the stretcher, ready to go.
Wow.
We'll move the patient over, make sure that first defibrillator pad is placed in the posterior distribution, lay him down on the back of the Lucas device, attach the top of it, and hit start.
Perfect.
Less
So
than
fast.
10 seconds,
Right.
super fast. The AHA guidelines tell us that we need to do like 100 to 120 compressions per minute, compress 2 to 2.5 inches, allow full recoil, minimize pauses. It's a lot to remember actually, like while you're doing a code.
Right.
And then you're having to do like all these other things. And I think the mechanical devices do it better, at least in theory, than humans
Right.
would do it. And I think in the back of a moving ambulance, I mean, safety of the paramedic crew, I think that when you don't have but 1 or 2 people on your team, how are you going to keep the CPR going for a long duration of time?
Right.
And then just that cognitive offload of now I don't have to worry about am I going 100 to 120 compressions per minute.
Right. We just said it. I mean, I wish it was set it and forget it, but I also think that when we look at least the future of what we do in the back of an ambulance, I think a lot of it has to become that way. A lot of it has to become more automated, so we're relying less and less on the provider, because there's provider fatigue with CPR. There's all of these little idiosyncrasies when it comes to, did I place the tube right, things like that, that I think until we start to recognize that we can rely on that technology, we're not going to get there. So when you talk about that defibrillation piece, so we've talked about the CPR piece, when you think about defibrillation, what are some of the key components to a good defibrillation program?
Yeah, so cardiac arrest really has 3 phases. So there's the initial phase where they're probably the most likely to, if they have a shockable rhythm, shock out.
Right.
And then there's kind of like the cardiac phase, which is where the CPR really makes its difference. And then there's the kind of electrolyte abnormalities, and by that point the cat's out of the bag. So that entire process is probably about 20 minutes is the reality. And the best chance of getting people out is probably in the first 5 to 15 minutes.
Right.
And so this process of getting that mechanical device on, but also thinking ahead of time to have that posterior pad on, putting that anterior pad on as you're putting the anterior portion of the device, really speeds that up. So when you get to your first rhythm check, which is 2 minutes, you're looking at the monitor and you're saying, this is a shockable rhythm. I'm ready to go.
Do you, are you a bigger advocate of the anterior posterior versus the traditional,
I am, and
sternum
I think if you look at, so it's all about electrical vectors. And so I think the anterior to posterior just makes more sense in terms of vectors of the electricity going through.
Good point.
And you'll even see people talking about with like refractory ventricular fibrillation and ventricular tachycardia doing 2 sets of pads, because they're trying to, they're doubling down to get like increased vectors.
Interesting.
To get that shock to make the heart come out of whatever it's in.
Do you foresee a future where maybe we do have a device that has, maybe it's 8 pads, 10 pads, or maybe even the 12 lead itself could be doing that? I mean, is there a future for that?
There's a future for that. I don't see us going to 8 or 10 pads. I do think that the number of people that have refractory ventricular fibrillation, ventricular tachycardia is very small. So,
well, I'm thinking in just all of it. I mean, if you're talking about, let's give it more surface area to find the right path.
We may see that. We may see something like that. But I do think the anterior posterior is the better way. But I get it. Like if you haven't thought ahead, then you go with what works best. And so for some people, it's going to be this lateral anterior. But I just don't think we're quite getting the vector through the heart.
That's a good point. Well, when I think about it too, most of the times for those automated devices, you have to roll the patient. That's the perfect time to slap that thing on. And if you're right, if you're thinking ahead, so what are some of the tools that you can do? Do you have checklists, or what are some of the tools we could use in the field? Because sometimes, at least in the ER, you have maybe a little bit of time to start planning that. In the ambulance, we may have some time, but often we're just reacting. How can we make that process better?
Yeah, so I think checklist is okay, but I think it's also just important to look at, depends on what system you work in.
Sorry. I swallowed my spit word. Sorry. Okay. Checklists. Okay, there we go. Sorry.
So I think checklists are important, but I think you have to evaluate the system that you work in. So if you work in a system where you're doing a lot of intubations, for example, maybe intubation is the right thing to do. But if you're in a system where you're only doing like 9 or 10 in a year, well, we have evidence that shows us now that we should maybe be thinking about supraglottic devices or these 2nd generation iGels, and just putting that in, things that can speed up taking care of the patient, but let you keep focusing on CPR. And so I would be a huge advocate for going away from pre-hospital intubations and doing these supraglottic devices, unless you happen to work in a system that trains with intubations and you're ready to go. So it's just like technology, like we were talking about. Another example would be, instead of going for intravenous access, why don't we just use a humeral intraosseous access? It's a 15 gauge needle. It might as well be central access. You can push anything through an IO that you would push through an IV. The way I think of it is just a non-compressible vein.
Right.
So you can run anything through it, and it's been shown to be faster than IV access. It's been shown to get medications to the central circulation faster. So these are all just examples of things we can do, and each of these things that I'm talking about allow you to do what? Focus on the CPR, the thing that's
a good
made the
point.
biggest difference for patients.
Well, and I think the other thing too we lose is that the IO is it's stable. You flop somebody's arm around, you're probably going to lose the IV. You flop their arm around, it's jammed in the bone. I mean, you're talking that thing's not going to, it can come out. It's higher likely that it won't. What are in some of the final thoughts as you look at the next maybe even 5 years of CPR and where we're at with it? What do you think are going to be some of the big next steps?
Yeah, so the thing I think is most unfortunate is these highly stressful situations. We don't practice enough in them, and I forget who came up with the quote. I know the Navy SEALs like using it, but like we don't rise to our level of our expectations. We sink to the level of our training. This is one of the areas I see that we really need to work on going forward, is that we need to start using more simulation and training in these high stress environments and these patients, because you can't do this 8-9 times a year and do well at it.
Right, I completely agree.
And I think the evidence has borne that out. And so that's one thing I start seeing, that it's not just doing a course where you recertify once a year or once every 2 years. I think we need to start doing more simulation training, and we need to start having more things like this. We need to start evaluating our systems a little bit better to see what we're good at. And so that may not be a black and white answer where all systems are doing supraglottic devices, or all systems are doing intraosseous, or all systems are doing mechanical CPR. Maybe people work in a system where they have 5 man or woman teams, and
oh my gosh.
I know,
Yeah.
I'm not saying that it's common, but maybe that them spending the money on the mechanical CPR device doesn't make sense. And so I think we need to start thinking about these things going forward. But I definitely think that all these neat little gizmos and gadgets, we need to train with them.
Right.
It's not as simple as like, here's my $35,000 for a Lucas device. We need to train with it and figure out all the intricacies and go through the flow of how we're gonna apply this thing, where we can focus on that high quality CPR. And that would be my take home message to everyone. Dosing of epi, how you wanna give the epi, getting IV access, intubate, don't intubate, all these things don't matter. The only things, time and time again, high quality CPR, minimal interruptions, early defibrillation. So we need to be thinking about things and the processes to help optimize that for our patients.
That's a great point. Doc, so where can people contact you via work or whatever, so that, I mean, they may hear this and go, man, I really like this person, I want to know more information. How can they get a hold of you?
So a couple of ways. So first of all, I run a blog and a podcast of my own called Rebel EM and Rebel Cast.
Cool.
All you have to do is go to www.rebelem.com, and you'll find there, and there's an About Us page where you can get a hold of me.
Cool.
Or people can just follow me on social media. I have a Twitter account. It's SRREZAIE. That's it. That's my handle.
Awesome. Wow. Doc, thank you so much. I really appreciate it. And you're cool because you're already a podcaster. I think that's the coolest thing ever. Thank you. And for more great content from EMS World Expo, keep looking back to this page. I'm Chris Montero for the EMS Garage and the EMS World podcast smash up here at EMS World Expo 2018.